Hi everybody, this is Dr. Peters, and I'm going to do a quick video update of this week. You had arthritis. As you can see, I'm sitting outside because it's such a nice afternoon. So this is where I'm at. So hopefully when you're watching, it's not raining or anything because it's really nice out now. Okay, so you went over arthritis. So one thing I just want to get clear is the difference between osteoarthritis and rheumatoid arthritis, and just some different treatments. So remember, osteoarthritis is more of a degeneration of the actual joints, whereas rheumatoid arthritis is an autoimmune, so it's your own body attacking the joints. So I'm going to flip to the screen. Hopefully you can see it. So these are some differences between osteoarthritis and rheumatoid. So one thing to point out is osteoarthritis, you're going to get up in the morning and you're going to be really stiff. And particularly these people get pain in the, as you can see in the picture, the distal joints in the fingers. So you have your distal, which is the Herberger's nodes, and then the next joint in the hands are Bouchard nodes, and those are just nodes from degeneration of the tissue in the joint. So that's osteoarthritis. You get up, you are stiff, but then as you get going, and a lot of times we tell people to get in the shower to loosen up the joints, and then it shouldn't be as stiff throughout the day. So if you keep having stiffness that's actually getting worse through the day or continuing through the day, and you're having swollen joints that are that could be more of an inflammation, rheumatoid arthritis issue. And as you can see on the pictures here, where the different joints are affected than the osteoarthritis. And some are similar, like you can see the knees are affected too. But there's definitely a lot more joints in rheumatoid arthritis. It's autoimmune, and so if your body's attacking itself, it's going to be like that 24 hours a day, unless you're on some medication, like the IV medications to help. So I hope that helps. So these people with osteoarthritis will have pain with moving the joint. So if somebody comes in to see me with knee pain, I'm going to assess their knee, and they're going to have pain when they're moving their knee back and forth. Doesn't necessarily mean it's stiff, but they're going to have pain, although stiffness and pain do go together. So in the morning, both rheumatoid and osteoarthritis are going to have stiffness and pain because that just goes hand in hand. But as the day goes on, the osteoarthritis should, your joint should loosen up. And you should not have any stiffness. You still could have some pain. Rheumatoid arthritis, you're just going to feel stiff all day long. So remember also the Herberger's nodes is that distal joint, and then that's an osteoarthritis, and then the Bouchard nodes are the second joint in the hands. So it's that next blue spot. I think you can see my mouse right in here, the second one's Herberger's nodes. So if you have a swollen or if you have a painful neck or hip joint, it's not that's not a Herberger node, so that's particular to these distal joints in the fingers. So just so you know that. Knees are very common to have osteoarthritis, as well as rheumatoid, but right now I'm talking about osteoarthritis. But stiffness should actually go away with movement with these people. And these people, it actually does not go away, or it becomes worse through the day. All right. Canes really help with both of these people. So that's some good education to give the patient. And again, loosening up the joints in the morning. Some people with osteoarthritis, glucosamine, chondroitin that you can get over the counter is supposed to help with osteoarthritis, and there's some good evidence behind that, so that's not a bad idea to recommend that. Again, I said using the cane. Also, as far as pain medications, Tylenol is recommended. You can take some anti-inflammatories, but remember, osteoarthritis is really not an inflammation issue, although there is some research out there now to say, maybe they could have some inflammatory flare-up, but we have to be really careful with NSAIDs because of the GI bleed issue. It's also metabolized in the kidney, so you just have to be careful, especially with these elderly people. We've seen a lot of GI bleeds, so you have to really weigh the risks and the benefits. With Tylenol, and I have another page right here. This is really good. I just pulled this up on Google, but it's true that you should not go over 4,000 milligrams a day or 4 grams a day. So you have to be careful again and do a lot of teaching. Just because it's over the counter doesn't mean it's safe. So 500 milligram pills, you can take up to 2 every 8 hours or twice a day. So the highest dose that you can ever take is 4 grams a day. That would be 8 extra strengths or 12 regular strengths. Because it's metabolized in the liver and it can cause liver issues, especially people that are drinking alcohol on top of it. So just make sure that you are doing that teaching. All right, so let me go back to this picture and let's talk about rheumatoid again. So with rheumatoid arthritis being definitely an inflammatory issue, maybe despite medications, or if you're having a flare-up, because you don't want the joint becoming destroyed, because that's basically what can happen. The synovial tissue here, it flares up, and you can actually have joint destruction. And these people need to be treated. So sometimes prednisone is used to help reduce that inflammation. In the meantime, you're thinking about maybe some IV biologic medications. And so with prednisone, we want to do some teaching with that. We want to give some side effects, short-term side effects that can cause anxiety, give you a lot of energy, make you hungry. Long-term side effects that can actually cause that weight gain, Cushing's type symptoms, as well as it can bring your blood sugar up, and you have to watch people that are diabetic. So that's something to really look for. Okay. Let me see here. So people with rheumatoid arthritis really have a lot of life changes. So again, with a lot of other diseases, people can have depression and just difficulty, period. So it's really good to remember to have open-ended questions and empathize with the patient. Not sympathize, but empathize with the patient. Like, tell me more of what's going on right now when you see them. One thing also to go back to, patients that are on ibuprofen or naproxen for anything, remember GI bleeds. So what are you going to look for? What's your patient going to tell you for you to think, I wonder if they have a GI bleed? Are they having dark stools? Are they fatigued? Are they pale? When you're doing your assessment, are their nail beds pale? And so I've diagnosed anemia a lot, seeing the nail beds that are pale, but the dark stools are a definite sign that the patient will tell you. Also, one thing to talk about too is osteomyelitis. Osteomyelitis is an infection that gets into the bone. It can be dangerous, but these people, once the infection gets into the bone, they need to be on long-term antibiotics. So these people usually have a PICC line. Some people are in rehab nursing homes in their short-term area, but they're on IV antibiotics for quite a long time. So just to keep you up on that, just to remember that it's long-term, sometimes greater than 6 weeks of antibiotics, because that can be very dangerous for, the infection gets into the joint, so it takes a long time for that to penetrate and to really kill the organism, or the organism to eradicate. Let's see. Also know that, remember, with rheumatoid arthritis and osteoarthritis, you can have nodules. Osteoarthritis is a little different. You'll have nodules, those nodes they're called, which is just buildup of cartilage over time because of the degeneration of the joint, whereas rheumatoid arthritis is actual joint destruction, and you can have these nodules, which could be part of the inflammation process. So these people, and it can be the nodules can be quite pronounced. So you have to be really careful with these patients if they're, watch if they're inpatient, changing positions, because now they have nodules or nodes or nodules that are not supposed to be there. So you have to watch for skin breakdown of these people. I want to make sure that I have all of my notes here. So with either of these and any other disease, you are going to treat symptoms as they come up that maybe not even be related to this. So for example, if you're seeing a patient with rheumatoid arthritis and they're like, I have really dry eyes. Well, okay, what are we going to do? We're going to give them artificial tears probably. Okay, so just remember, just because you have these illnesses or diseases, you are still going to have symptoms of other things that may not be related, but the point is to make the patient feel comfortable. So if we can easily make the patient feel comfortable by doing, easy measures that aren't going to hurt the patient, but yet make the patient feel better, that's important. Okay. As far as laminectomy, just kind of understand what happens in the post-op period for laminectomies. And it's really not too much different than other surgery. Just know what your risks are post-op. With the laminectomy, think about if you're having back surgery, you might be flat for a little while. You want to watch for, again, skin breakdown. Are they going to be turned every 2 hours? But usually they get those people up quicker than they used to. But still, that is a possibility. I think that is about it. Yep, that's all I got. All right, so that was your review for osteoarthritis, arthritis, rheumatoid arthritis, and I will see you tomorrow night on our session, and that's about it. All right, take care.